depending on the patient, it seems like ET or PV may be easily managed. So how are they treated? Let's start with essential thrombocythemia, or ET.
So ET is a disease in which, first and foremost, we're trying to reduce the risk of thrombosis, clotting, and or hemorrhage, bleeding. So typically ET patients are risk stratified by low risk or high risk. It's almost simply based on their age, whether they've had a clot in the past. Mm-hmm. And some systems now even incorporate other factors like mutation status. And you tailor the treatment based on their risk score. So low-risk ET patients don't necessarily need to be treated. They can be followed expectantly and watched. The height of the platelet count does not predict thrombotic risk, so we don't treat the platelet count per se. A high-risk patient is at high risk for clotting. So these patients almost invariably are getting aspirin at a baseline, and they are often on cytoreductive therapy. And sometimes that is chemotherapy, like hydroxyurea. Sometimes it's a non-chemotherapeutic option like anagrelide. And sometimes it's a biologic therapy like interferon alpha, either 2A, Pegasus, or 2B, ropeg interferon. And these are therapies that have rationale, that have clinical data, that have demonstrated reduction in risk of clotting, which again is the reason why we treat higher risk ET patients.
Yeah. And what about PV, polycythemia vera?
So in polycythemia vera, it's similar to ET. We risk stratify patients low and high risk based on age and clotting history. In whether you're low risk or high risk, we give PV patients aspirin at least once daily, and we look to keep their hematocrit below a threshold of 45%, and sometimes in women we even go lower to 42%. But the idea is that controlling the hematocrit, which is one of the red blood cell indices, you reduce the risk of having clots, and that's been shown actually many years ago and reinforced. And a very well-known study called the CytoPV study in Italy documented that if you keep a hematocrit less than 45%, so stringent control versus allowing for less stringent control between 45 to 50, that you reduce by fourfold the number of cardiovascular events that can occur. So we know that controlling the hematocrit is important, and that can be done again with hydroxyurea, interferon, and ruxolitinib, the JAK2 inhibitor, is also approved specifically for patients who have intolerance or refractory to hydroxyurea, but also importantly as a drug that can address, probably better than most drugs in this field, the symptom burden that can be problematic for some of those patients. But it's really about controlling the hematocrit.
Yeah. Since myelofibrosis is a progressive condition, I imagine that makes it more difficult to manage. So what else is available for patients with myelofibrosis?
The first line of treatment is typically a JAK inhibitor, although I would say that there are a subset of patients. There are patients you sometimes meet that have very low risk disease. They don't have those clinical variables we discussed before that could uptick their risk score. And some of those patients can be watched. And interestingly, there are a subset of patients that can have an indolent or slow form of the disease where they don't have aggressive changes in their disease, their blood counts, their symptoms, their spleen, and don't need immediate treatment. Most patients would benefit from a JAK inhibitor, although there are a subset of patients where their issue is less symptom and spleen burden, and it's more anemia. So we take those patients where anemia is the focus. We look at their erythropoietin level, which is their endogenous hormone level that regulates red blood cell production. If it's low, we give them a lab-based form of erythropoietin, something called Procrit or Aranesp. If it's high, we will move on. We can use a drug called danazol, which is a synthetic male androgen, which can improve hemoglobin levels 20 to 40% of patients. Or we will use a drug called lenalidomide, which is an immunomodulatory drug. And more recently, there's a drug in testing called luspatercept, which is an activin ligand trap. So there are a growing armamentarium of drugs that can be used to try to alleviate the anemia, which is present in and can be a significant issue in about a quarter of patients with myelofibrosis up front at time of diagnosis, or about 75% through the course of their disease. So that's an unmet need that still requires attention and may alter the treatment plan for a given patient.
What about stem cell transplants?
So we relegate stem cell transplant for those patients, as mentioned before, that are higher risk, because we think that the potential benefit to risk ratio is in favor of transplant. Transplant is really a modality that is the only modality that offers the potential for cure, but it's also a modality that holds a significant risk of morbidity and mortality associated with it. So it has to really be taken very seriously. It can't be kind of treatment you would think of as a last resort at the last minute. One should see a transplanter if they're interested in that therapy, and see it early on in the disease course, in my opinion, to start that dialogue, and then figure out when is the optimal time to employ a bone marrow transplant, which is not a surgical procedure. It's often thought to be surgical. It's not a transplant of an organ, it's a transplant of hematopoietic cells. So it's really an infusion of stem cells that then end up in the person's bone marrow and then create a whole new hematopoietic system and immune system. And with that, you can have an immune system that then goes after the myelofibrosis stem cells. That's called graft versus leukemia effect. But with that, you can get graft versus host disease, which is when the new graft, the new immune system doesn't always recognize well the person's own tissues, whether it's the liver or the lung or the skin, and you can have immunologic reactions to that. So that's a complex discussion, but transplant typically for patients less than 70 years of age who have higher risk myelofibrosis, or even up to 75 if they have a good performance status, and as we said, don't have a lot of comorbid issues, with a goal of cure. So if you have someone where their goal is to try to maximize their time out of the hospital, and they're not focused on longevity, they're focused on quality of life, that may not be an appropriate patient for transplantation. So I think a very upfront, honest, and a transparent discussion with the patient about what to expect with transplant, what are the pros and cons, what are the risks involved, and importantly, does it match up with their expectations or their desires?